Olia and Gwalior OBGYN Society. Myself, Dr. Manila, I bring greetings from Indore, and I would like to introduce Dr. Rosa Olia at the outset. She's going to give a welcome address. Kindly project CV of Dr. Rosa Olia. She is currently president of Gwalior OBGYN Society, a very respectful person in Foxy, and she has held many important positions so far. She was vice president of Foxy 2014. She was chairperson of Adolescent Health Committee 2012, and I know her since then. And she has been active in Foxy over a decade now. Currently, she is also chairperson of State Bar Council, Madhya Pradesh.
Thank you, Manila.
Yeah,
Thank
ma'am,
you
let
so
me
much.
read. Yeah.
I think I'm so grateful to you. Thank you for accepting to be introducing and starting the whole thing. My
No
secretary
problem.
is unfortunately out of town, so I requested her. So welcome, a great warm welcome to all my faculty who are here. I'll be introducing Dr. Sunita shortly, but all the delegates who are here, and I know all of you have got really busy time, but still you've taken out your times. So hypertensive disorders of pregnancy was a demand from my friends in Gwalior Obstetric Gynec Society. We really wanted to have all of you in person in Gwalior, but I know all of you all are busy. And what a blessing, what an honor for me to have our president-elect, my dear friend, Dr. Sunita Tandulwarkar, to be our chief guest today. And I'll be talking, of course, Manila will be introducing her, but let me tell all of you that she has got such beautiful plans made for the whole year once she takes away. I was with her recently in Bombay, and I've seen, being so busy, I've never seen her grumble to say she's tired. So we are going to look after a very dynamic year ahead with her. Of course, she is not only a laparoscopic surgeon, she is infertility specialist. So two things together, a rare combination for most of our gynecologists. So we are going to look forward to display her CV so that Manila can talk more about it. I'm really grateful to you, Dr. Sunita, for being with us.
So thank you, Dr. Rosa. I'm going to read a very accomplished CV.
Manila, please, no need to read my CV.
Ma'am,
Let me only speak. No, Manila. Listen, if people don't know me, then I don't know whether I got elected is the right thing or not. So let's not talk about the CV. Close down. It's better I see you all together. I don't need to be introduced. See, this is what Rosa said was a hypertensive disorder. Everyone is waiting. And let me tell you, we enjoy reading and talking with each other. It's going live. We should not be taking our academic time at all. I would like to say only a few words about Rosa. So Rosa, as you say, she is a very elegant, Rosa has a different aura altogether. We are friends for decades now. I had gone to her daughter's marriage in Australia. Where was it? Bali. We had been to Bali. And see, when you attend each other's family function, this destination, you know how close you are. So it's always, but what was very, one important thing is, one feels endoscopy, it's not my cup of tea, now I'm passing. The difference I want to tell about Rosa was a decade ago, she flew down and stayed 1 week just to be with me, understanding and learning endoscopy. And I realized how passionate she is. I know she's very well known as an obstetrician, a great gynecologist in Gwalior, but she had an enthusiasm to learn endoscopy. And 1 week, she stayed with me. We stayed together in house. And we traveled together to the hospital and all. That was a lovely time. But what I learned was a passion a lady will have. And when anyone is passionate and she becomes the leader, I'm obviously that the organization, the society is taken to the higher level. Rosa will be closely working with me in my Foxy presidential year also. But I see Dr. Jyoti Bindal madam here, who has always blessed. And I know the amount of respect anyone can have in MP is Dr. Jyoti Bindal ma'am. You have students all across and they speak a volume about you. So it's an honor to have you. And Kavita, Monica, Manila, all of you I know so closely. Monica has worked very hard along with Dr. Randir, and they both have a very special place in my heart. And you have chosen Dr. Surekha Taide, the right person. She is a research oriented, she is always well read. So I'm very sure that this will be one of the best academic. Even if my video is on, video is off, I'm listening to you all. Thank you so much for having me with you all. And it's, believe me, it's my honor to be with you all. Thank you.
Thank you so much, Dr. Sunita, for your kind words and the words of appreciation. It's an honor to have you today with us. And I know you're going to rock in your presidential year, and we're looking forward to be closely working with you as promised. So thank you so much.
I request all of you to join AICOG. It will be one of the best AICOG. The venue is fantabulous. We could not attend Nita Ambani's wedding. You can see the wedding halls though. And 9 January evening, be there for an installation. Okay?
Definitely.
Okay.
Congratulations in advance.
Thank you. Thank you.
Congratulations.
Dr.
Most
Jyoti
of us
Bindal,
should
madam, I
join.
look forward to having you in AICOG.
I'll speak to you about this.
Okay.
So as we move on, thank you, Dr. Sunita. Thank you so much for coming. So as we move on, I would like to introduce my guest of honor, Dr. Jyoti Bindal, all the way from UK. I know it has been difficult for you to be with me in person for this Zoom, for this meeting in Gwalior. Often I've been calling you, but however, first of all, hearty congratulations for being awarded the Honorable FRCOG from the UK Royal College. You've been there, you're going to get it on 28, 29. So let me just in advance give you the congratulations on behalf of everyone. You've been very closely working with Gwalior. You're in Indore, I know, but you've been always with me in person, right through the elections and right through the the processes we've been through, and the proper guidance, I would say, unbiased proper guidance from you. It will always be with me, and you're part of the family as always. So Manila, please read her CV.
Yeah, it's my privilege to introduce Professor Dr. Jyoti Bindal.
As Sunita said, Manila, we're going to skip this.
Ma'am, my job
I
is
guess we are
nowhere
quick
if I don't read.
connected. No, that's okay. Everybody knows. That's fine.
Yeah,
No,
ma'am,
I think, madam, excuse me. Good evening, madam. I think Manila should read it. It is something nice. We get to learn a lot of things.
and
That's
maybe
okay.
on our faculty link we know each other, but the audience who is listening from
That's
different
okay.
corners of India.
Let's skip this and move on, because academics is something we all want to listen to.
So, ma'am, we
Right?
want to listen few words of wisdom from you.
Sure.
And-
I think it's a great honor to be sharing the platform with Sunita. Thank you so much, Rosa, for giving me this opportunity. Me and Rosa, we go back 2 generations, so she's like family. I mean, I've seen her coming as a bride in this house, Ulay house, and I've seen her working her way together. The best part about Rosa, I would say, is that every gynecologist somehow or the other gets in a group or other. She's the most non-controversial person ever I've seen. So that's probably a very big USP for Rosa. Sunita, I came to know about her very recently, just a few months before her election. Whatever I knew about her made me go all the way for her. But when she came to Indore and I heard her journey, oh my God, that was amazing. So again, my respect for her went up a notch. Manila, I've worked very closely, and I think Medical College Indore lost a great hand when you decided to leave it. Kavita, everybody knows my feelings for Kavita because she's my successor as MPOC's president. Monica, I know a lot about her zeal and her enthusiasm. Although I got introduced to her as the mother of her daughter, initially that was my first introduction to and Surekha Taide is, again, as Sunita said, is a very academic and research oriented. So everybody we have here is the right combination to discuss hypertension in pregnancy. And as we all know, it still happens to be #1 cause of maternal mortality, and we must do serious stuff about the preventive aspects. Thank you, Rosa, for picking up this topic. And once again, all the best.
Thank you so much, Dr. Binder, for your kind words. And it's such a privilege to have you today. I know you've been very busy, but we do appreciate you giving us time out. Thank you so much. I go over to our next guest of honor, and thank you so much for all of you to be so brief and we just move forward so quickly. Dr. Kavita Singh, who but Dr. Kavita Singh, and she's been always supportive of Gwalior Gynec Society. She's a president of AMPOC. We all are knowing about it. And whenever she comes to Gwalior, she's a great support. I was happy to have her during the last state conference on oncology as my guest, faculty guest. So Kavita, over to you. Manila, can you please share her?
So it's an honor. We have a lot of professors today, and Professor Dr. Kavita Singh needs no introduction. I know that, but she still has held many big positions. I must say she's currently dean. She's moved on from Jabalpur to Bhopal. I think that people should know. And now currently she is dean of Gandhi Medical College, Bhopal. Ma'am, you have such an accomplished CV. I have read word by word while I was practicing it. And I'm so happy to hear so much, so many awards and so many achievements every one of you have. And we, people like us, look forward to be like you sometime. Thank you, ma'am. Can we have few words of honor from you?
Yeah, thank you so much, Dr. Rosa Oliai, for inviting me for this very important webinar. And whatever Madam Bindal has said, as a guest of honor, I agree word to word with her. So my regards to Chief Guest, Dr. Tandulwarkar and Dr. Bindal, and my respect and love to everyone in the webinar. And I'm sure I have shared this link with my students here as well as in Jabalpur and also on the state platform, because it is a topic to be everyone knows everything about it, but still there is always a scope for revising and relearning something new. And we cannot have a better person than Surekha speaking on the subject. So my best wishes to you, Dr. Rosa and Dr. Manila. Thank you so much for inviting me. Thank you.
Thank you, Dr. Kavita. Such a pleasure to have you. And thank you for sharing the link with all the PGs. I can see a lot of delegates here, more than 60 we have right now. And I think it will go on increasing at this time of the day, in the evening. Thank you so much to be with us. And you mentioned it correctly with Dr. Surekha, a good friend of mine. We are always in touch on phone regarding, cases, because she is running one of the most I must say, important ICUs, obstetric ICUs, and she's an expert on this subject. In fact, I've been discussing few cases with her as well, and I thought, why not calling her as a speaker? And she can do a great job. Physically, she was not able to come because of the train connection to the Gwalior airport and rail, so we thought we have a Zoom meeting. Thank you so much, Dr. Kavita, and thank you, Surekha, patiently for your turn to come to speak. Here, I would also like to mention about my two other chairpersons. Manila, I'll be, of course, introducing right now. Dr. Monica Singh from Bhopal. She is, of course, a very wonderful person I've been knowing, doing such great work. We knew her in ISAR, but now she's in Foxy and doing great work in all aspects, in everywhere I see Monica, in all the big conferences. Monica, thank you for sharing the link in all the groups. I've been seeing the link being shared. Before I could share, it was already there. I really appreciate that. And you've been always, with your gentle voice and the modulated way that you talk, is really appreciable. A word with Dr. Sumitra Yadav, who was, I remember her from the days she was with me in Gwalior. Very hardworking, excellent, in her academic. And the moment she's taken over as a president of Indore, she was in touch with me and she wanted to do things together jointly. So I think this time, Sumitra, I'm with you. We will do wonders. And I'm sure during your tenure, you will do great work. And of course, as a department, you've done so much and in Indore. So can I have my dear Manila's presentation that I can introduce this beautiful girl. Let me tell all of you before that, Manila is such a wonderful person, a golden heart, beside the beautiful resume that she has. She is the past president of Indore Obstetric Gynec Society. I must say, at a very young age, she became the president. She has been the Joint Secretary of AICUG 22 Indore. This was the first AICUG in Madhya Pradesh, and being a Joint Secretary is a big thing, Manila. So it shows your caliber. She is a member of the
Ma'am, we should
Drugs Committee.
right.
And you have also been the professor of the medical college working at Indore. And I just heard that they have lost a good person. Now that you are into private practice and you're doing wonders in your private practice as a director of Coral Hospital and Research Center and Mahi Women's Center in Indore. So I wish you all the best. And for the understanding of rest of the friends here, Manila and me have been giving a lot of publications together. And she's a great academician. And thank you, Manila, for all the work that you're doing. So
Thank you.
Manila, over to you for introducing the rest of the faculty.
Yes, ma'am. Now, I think I should get some time to introduce my two co-chairperson because both of them are very close to my heart. Let me have CV of Professor Dr. Sumitra Yadav, Madam, first. So thank you, Rosa ma'am, for introducing me so nicely. I'm really, what should I say? I'm really thankful to you for giving me this opportunity. And I would like to invite and welcome Professor Dr. Sumitra Yadav. She's already there and she's joined us. And I know ma'am since many, many years, ever since I'm in Indore. She had been a professor and she has been professor and unit head where I was working, with teaching experience of over 33 years. And she was recently head of Department of OBGYN at MGM Medical College. And I'm seeing her working very hard for HIV patient and STD patient. And she has been a member and technical expert at NACO from 2006 till date. And currently she is the president of Indore OBGYN Society, and we're looking forward very soon. Tomorrow only she will be installed, and our first CME would be there under her leadership, and we're looking forward for a great year ahead under her leadership. And we know she is a great teacher, very favorite of students, and she has many publication and awards to her this resume. And I welcome you, ma'am. Next CV for Dr.
Thank you, Manila. I'm driving. Thank you very much. So I'm unable to participate like that, but I'm listening to every word of yours. Thank you very much.
Thank you, ma'am. Our second chairperson, Dr. Monica Singh, a very close friend of mine. And these days we are seeing Monica ma'am everywhere. And she is a great academician other than a beautiful heart. And she is a consultant in fertility specialist from Bhopal. Nobody wants to be introduced, no? Because Rosa ma'am is already introducing very beautifully.
You can speak.
So I would
Okay, I think everybody knows. Yeah. So it's okay. I mean, everybody's a friend, everybody's a senior. It's okay. Let's listen to Surekha ma'am now. It's okay. Thank you so much, Manila. Thank you.
Monica ma'am, would you like to read CV for an invite speaker, Professor Dr. Surekha Taire ma'am?
I think Rosa ma'am would like to do the honors, ma'am.
No, you can do that, Monica. Just a little introduction about Dr. Surekha is that who doesn't know her actually? For those young PG, we have over 100 delegates right now, Dr. Surekha, for your information. So see, the topic has been a hot one that everybody wants to be with. So Dr. Surekha is with an experience in, of course, her resume will be read by Dr. Monica in detail, but she has been doing all these high risk and high level intensity of, ICUs for obstetricians. So the way to use, when to use the hypertensive medications, injectables, when to shift to injectables, when to use magnesium sulfate, what is the dose of magnesium sulfate? Especially I requested her to talk in line with people who have got small nursing homes. A lot of us have got our own nursing homes and we manage single-handed obstetricians. We don't want to shift the patient in shock or with convulsions. We can do certain things in advance so that when they reach the higher center, they can be taken care of. Who better than my dear Dr. Surekha Tayade? So, Monica, please introduce her in detail. Surekha, allow her to introduce you in detail now.
Yeah, thank you. But please be brief, I think.
Yes,
Monica.
ma'am, I'll be brief. And Dr. Surekha has already obliged me such a lot. She has done a complete committee program with us. So Dr. Surekha Tade is one person who knows research. So that is what is most important, because in India, what is lacking is our presentation of the amount of work we are doing. So unless we know the logistics, we know the statistics, and we know how to present that data of our country, all over in the world, we'll not be able to, improve ourselves and not be able to tell others that how much work we are doing and what incredible work. So Surekha ma'am is master of all trades. So I
Something, Monica,
thank
I
you.
add something to her introduction that
Yes, ma'am.
recently I've done my ACME, and my project was she was my mentoring me as a mentor, and the concept which I brought in front of her, she guided so well that I was the winner in the entire 30 medical colleges. So all credit to
She has
her.
won the best research for her ACME, that is the advanced course in medical education. Congratulations, ma'am. It was my proud privilege to be your guide and mentor. I mean, I'm so in age, I'm so young, but thankfully I had a great learner.
No. It was my privilege entirely. Thank you so much.
It speaks volume of the amount of effort you put in, Kavita ma'am, to better yourself. And about Surekha ma'am, she goes at the speed of a supersonic jet. Before
Yes.
it's
For,
gone. She's
yes,
at
for
another
Surekha.
level. She's at another level, and she continues to inspire thousands of Foxians. And Surekha ma'am, we are blessed to be chairing your session. We are so honored, and thank you for the privilege, Rosa ma'am. Thank you so much, Dr. Manila, for the invitation. And we can't wait to listen to you now, ma'am.
Thank you very much. I think I am blessed and honored to have such an august audience. And as rightly said, all professors here chairing and very great accomplished people here. I must pay my respects to Dr. Sunita Tandurwadkar, our president-elect of Foxy. And of course, Dr. Rosa, my dear friend. We have been discussing so much. Physically and online. And yes, this is a great way of sharing knowledge. So Manila, thank you, both of you, for inviting me here.
I must put in a word. It's been a great fun knowing Dr. Surekha for a very, very long time. And we have been into everything together. So it is an honor for me to chair her session. I will thoroughly enjoy it. Thank you.
Yeah, thank you very much. I think we can go ahead. And it is a very, very important topic of managing hypertensive disorders in pregnancy and prevention of eclampsia with magnesium sulfate. Next slide, please. I bring greetings from my medical college, that is Punjab Rao Deshmukh Medical College, Amravati, and we have been doing a lot of skill training, and this is how the simulation lab looks when we train our healthcare providers. And especially, I think it's very important that obstetrics, you should have the skill training and a very good team who knows what to do and when to do what, what amount and how to assist. That's very, very important. Next slide. Yes, and thank you very much for inviting me here. And as the chair of the clinical research committee, I bring greetings from Proxy as well. Next slide, please. So hypertensive disorders of pregnancy, we all know the incidence is on the rise. In fact, we see around 10 to 11%. In fact, if we have a high-risk practice unit, we see around 15% of our pregnancies are complicated with hypertensive disorders, because there are a lot of risk factors, and these risk factors like obesity, high maternal age, that is more than 35 years, low socioeconomic status. I've been working in rural area, and I know that pregnancy-related anxiety, chronic hypertension, diabetes, nulliparity. Of course, nulliparity is one of the very important risk factors. And we do know that now we are classifying the hypertension as severe and non-severe. Severe is when the blood pressure goes above 160 in systolic and above 110 in diastolic, whereas if it is less than that, we would call it a non-severe type of hypertension. Next slide, please. So these are the categories. So when we are talking of hypertensive disorders, we take 20 weeks of gestation as the gestational age as the cutoff, before which, if we have two measurements of blood pressure, which are rising blood pressure at least 4 hours apart during the same visit or in 2 consecutive visits, and if there is a rise in blood pressure above 140 systolic and 90 diastolic with no proteinuria, then we would be calling as chronic hypertension. So prior to 20 weeks, if we find that there is a blood pressure rise, we will label as chronic hypertension. And if there is new onset of proteinuria in such a woman with rise in blood pressure and there is even evidence of maternal organ dysfunction, then we would call it as a superimposed preeclampsia. So that is when we find the blood pressure rise before 20 weeks of gestation. After 20 weeks of gestation, we have gestational hypertension with at least one of the following, that is a proteinuria, maternal organ dysfunction, AST-ALT doubling, pulmonary edema, uteroplacental dysfunction. So all these are organ dysfunctions or organ damage or end organ damage, which we label as preeclampsia. And if there is no proteinuria, then that is called as a gestational hypertension. Other categories are white coat hypertension. Now, white coat hypertension is when the patient is all right at home, but when she visits your clinic, then the blood pressure is above 140/90. So domiciliary blood pressure is less, and as soon as she visits clinic or hospital, there is a blood pressure rise. Masked hypertension, normal at a clinic or office, and elevated at other times. Many a times, the blood pressure may rise in the night somewhere, and we may not even know that the patient is having high blood pressure, because when she visits the clinic, at that time, the blood pressure is normal. Next slide, please. So basically, we are talking of chronic hypertension, gestational hypertension, and preeclampsia. In preeclampsia, we are having early onset. Early onset is before 28 weeks of gestation, and late onset is after 28 weeks of gestation. So that is the cutoff. And early onset preeclampsia has its own complications and has, maternal deterioration as well as fetal complications, more so in early onset preeclampsia. Next slide, please. So when we are talking of the pathogenesis, it's a two-stage process. In the stage 1, abnormal placentation and vascular remodeling. This leads to decreased placental perfusion, and added there could be some maternal factors like it could be genetics, so sibling or first degree relatives, the mother previously having hypertension in pregnancy, or otherwise behavioral, maybe related to stress, environmental factors. All these contribute, and what we are getting then is the maternal syndrome of preeclampsia with endothelial dysfunction. Next slide. So what we see in a normal, in a non-pregnant, of course, we are seeing the spiral arteries going up to the myometrium. And in normal pregnancy, what happens? There is a very good, trophoblastic invasion is seen, and you can see that, the vessels, they are nicely dilated, and the blood flow to the up to the spiral arteries. As you can see, the invasion is seen. Whereas in the preeclampsia case, this trophoblastic invasion, which should have occurred, is not present, and that's why you can see the vessels are not that much dilated, as you can see, and they are not, the peripheral resistance which should fall is not there in the preeclampsia patient. So as you can see, abnormal trophoblastic invasion is the primary pathophysiology behind preeclampsia. Next slide. So it's very, very important that we should know how to take a blood pressure in the clinic. inaccuracies in an improper blood pressure measurement itself, can lead to either too many cases being detected, or many a times you are finding that the cases may not be picked up during the antenatal visit. So we have to train our staff, our postgraduates, interns, whoever is primarily taking the blood pressure. So what is suggested is we should not be talking with the patient when we have this habit of relaxing the patient. So we have go into a conversation, because what happens when you start talking or even active listening from the side of the patient will lead to an addition of 10 millimeter of mercury. So we need to relax the patient but not get on talking with her. Using the correct cuff size is important. If it is too small, then there is a rise in 2 to 10 millimeters of mercury in the blood pressure. And if it is large incorrect blood pressure, again that is not proper. So that's very important that you should have a correct cuff size. And then of course the cuff should be put on the bare arm. Many times we find that a patient will wear long sleeves, and she may not be so much comfortable to pull over the sleeves as well. But it is important that the cuff is placed on the bare arm, and cuff over a clothing actually adds 5 to 50 millimeters of mercury of blood pressure. So that's very important. It's that it should be on the bare arm. And of course, supporting the arm at the heart level, unsupported arm adds 10 millimeters of mercury. Bladder should be empty. Full bladder adds 10 millimeters. Keep legs uncrossed. If she's crossing her legs as well, there is 2 to 8 millimeters of rise in the blood pressure. And of course, the back of the lady has to be supported. Either if she is sitting on a chair, then the back has to be nicely supported and she has to be in a relaxed stance. Otherwise, this unsupported back and feet adds around 6 millimeters of mercury. So you can see that we have to train ourselves as well as our staff to take the blood pressure correctly. And also, the patient should not be having some tea or coffee prior to taking the blood pressure. That also adds to the blood pressure. Next slide, please. So what is chronic hypertension? We have discussed blood pressure above 140/90 before 20 weeks of gestation, or if the patient is already on an antihypertensive treatment, and the persistence of hypertension beyond 12 weeks after delivery. So that we would label as chronic hypertension. If we find such a patient in our clinic, what we are supposed to do? So apart from the investigations which we are already doing for our routine antenatal patient, we need to confirm that the complete blood count with the platelet count is available to us, LFT with the transaminases, the creatinine, blood urea creatinine, that is your renal function test, electrolytes, and as well as, we need to have the urine protein tested. So apart from the urine protein creatinine ratios is also important, and that should be done on a 24-hour urine. Okay, so that sample is important. Apart from that, if you find that the patient's age is, more than 35, and you find that the chronic hypertension is for a longer duration, it is good to have a physician opinion sought for this patient, and an ECG and an echo, if required, is helpful for this patient to let us know whether there is any decreased cardiac function. In fact, in the state of Tamil Nadu, echocardiography is mandatory for all women of all ages, whether there is hypertension or not, because sometimes we may miss the reduced cardiac function and later on the patient lands in cardiac complications. So for these women who are having chronic hypertension, it's very good if we can do a physician is brought in, and if we do an echo for this patient. Next slide, please. So next slide, yes. And gestational hypertension, so we have seen if it is prior to 20 weeks, chronic hypertension, after 20 weeks, previous slide on gestational hypertension. Okay, so we all know about this, and of course, if the previously normal blood pressures are there and there is no proteinuria, and you find that the blood pressure has risen, that is gestational hypertension, affecting around 7 to 8% of pregnancy, and if not taken well care of, then 15 to 20% of these women may land in preeclampsia. Next slide. So how do we manage hypertension in pregnancy? That is the issue. So first of all, if you would like to take some preventive measures, especially in a woman who's already having chronic hypertension, and now we do not want her to get a superimposed preeclampsia. So what we should be advising as a preventive measure? Definitely 75 to 150 milligram of aspirin. Nowadays, we are not talking of the low dose aspirin. We all are, because of the evidence suggested that 150 milligram of aspirin should be given in these women, and starting as early as 12 weeks of gestation until delivery. In fact, we are starting in our infertility patients even prior to 12 weeks. The patient is already receiving aspirin as a preventive measures. And of course, these women have to be counseled about weight management. Moderate degree of exercise is advisable, like walking, and of course, in pregnancy, we are not advising swimming or any new exercise, but of course, moderate degree of exercise, healthy eating, lowering the amount of salt, and of supplementation with calcium, vitamin C, vitamin D and folic acid. Other things like garlic and fish oil and all, not much evidence is supporting it, but in Ayurveda, garlic is suggested as an antihypertensive. So women do ask us whether they can take it. There is no harm, but not, we are not actively advising it. What we advise is calcium, vitamin D, and folic acid, of course, and no additional table salt, no achar, papad, all that we are going to advise our women. Now, when using medications to treat hypertension, what is your target blood pressure? Target blood pressure is 140 systolic and 90 diastolic. So that is our target, and that is what we are going to maintain. Next slide, please. Now, we also, just a minute. Yeah. So now when we are managing, some of our women with chronic hypertension may be already receiving some medication, some antihypertensive medications like ACE inhibitors, and we need to be very careful that as soon as we come to know that these women are receiving, as soon as we know that the pregnancy test is positive or confirmed, then we need to stop this ACE inhibitor, preferably within 2 working days of notification of pregnancy. So these are, and as far as the management is concerned, we all know that labetalol is the first line of management in gestational hypertension. Other drugs are also there like nifedipine or alpha-methyldopa, but yes, labetalol is the first line of management. Other things like hydrochlorothiazide is not advisable in pregnancy, but yes, nifedipine, methyldopa is advisable. Methyldopa nowadays, not available in many centers. So most of the centers are starting the antihypertensive management with labetalol. Next slide. So now let us talk about IV labetalol. And myself and Rosa were discussing one case of very high blood pressure who landed in eclampsia postpartum period. And I just talked about, the use of IV labetalol. All of us, all the clinicians, whether they are working in a private, very well versed and very comfortable in using IV labetalol. When should we use IV labetalol? It is used in severe hypertension, which is not controlled otherwise. So it is also called as a hypertensive crisis. That means you have used your usual measures. A patient has come to you with systolic 160 and diastolic more than 110 blood pressure. So a pregnant woman who is having diastolic blood pressure above 110, you have used your oral antihypertensive. Maybe you have given her a nifedipine, but her blood pressure has not responded. So that is when you call it a hypertensive crisis. So it is a severe hypertension, and herein you are going to advise IV labetalol to this patient. Now, labetalol, as we know, is a selective alpha and non-selective beta blocker. the alpha and beta blocking activities, they both contribute to lowering the blood pressure via vasodilatation as well as by slowing the heart rate. Now, when we are giving this IV labetalol, our goal is to reduce the blood pressure systolic up to 140 and diastolic up to 90. And we should not aim too much that, yes, we want it to come to 80 or 70 like that. Our blood pressure, if it is up to 90, that is good to us. So diastolic 90 is the goal. Now, you can see in the picture available as an ampule, which is of 4 ml ampule. So you can see is a big ampule. It is having 4 ml. And in that 4 ml, there is 20 milligram of labetalol. It also is available as a vial or 20 ml vial, which contains 100 milligram. So that is what, we have to make ourselves used to. One ampule is how much? One vial is how much? Next slide. How do we administer this? Now, our bolus dose of labetalol is 20 milligram. That is 4 ml over 2 minutes. So you have to be quite slow. So you need to put your hand on the pulse of the patient, and slowly over 2 minutes, the 4 ml of IV labetalol is given. That is 20 milligram. You take the blood pressure after 10 minutes. After injecting the first dose, you again take the blood pressure after 10 minutes. And if the blood pressure is not reducing, not getting control, you give the next dose, and that is again 20 milligrams. So 20, 20, 40, 80. So that is how you go, Now, if this patient requiring more than 3 doses, that total of 60 milligram over 30 minutes, that is when we think that this patient is not going to get covered with only bolus doses. The blood pressure is not getting control. So this is the patient who needs an IV infusion of labetalol. We should also remember that IV labetalol, the maximum dose is 30 milligram per day. Our target blood pressure, always remember, is 140 by 90 millimeters of mercury and not less than that. Do not go too much low. Okay. Now, next slide. The next question is for us, how do we start an infusion? What dilution? What should be our dosage? Being obstetricians, we are always afraid to start an infusion of an antihypertensive, and we need to have a physician by our side. But I think for us, it's very important that we know how to start an infusion as well. See, injectable IV bolus is not at all a problem. We have trained our postgraduates also. They are very, very safely and comfortably giving the IV labetalol, and it is not at all an issue when we give a IV labetalol. In fact, the regime should be, nicely printed and pasted in your labor rooms and wards so that everybody knows what is the schedule and how the labetalol has to be given. Now, for us, as far as infusion is concerned, you see that you take 100 ml of normal saline. That so 0.9% your 100 ml solution is there, out of which you take off 40 ml. What remains is a 60 ml. So in that 60 ml of normal saline, you are adding 200 milligram of labetalol. That is 40 ml. You take from the vial 40 ml and add to the 60 ml of normal saline, which makes it 100 ml. Let me repeat it. You had 100 ml in the bottle of normal saline. You have taken away 40 ml from it, and now you have added 40 ml of labetalol. The total volume becomes 100 ml. Your final concentration is 2 milligram per ml. How do you start the infusion? You start it at 20 milligram per hour. That is 10 ml per hour. And how you're going to adjust this? You should have an infusion pump, and in that infusion pump, you'll be able to, set it at 10 ml per hour so that the 20 milligram per hour is delivered to the patient. And you need to monitor the blood pressure. If the blood pressure is unresponsive to this infusion, then you can increase it by 20 milligram per hour every 20 minutes. So you took the blood pressure, you found at 20 minutes also it's not responding, then you have to increase the dose by 20 milligram per hour. Maximum rate is 160 milligram per hour. But we find that by up to 40 milligram, the patient starts responding very well. And with this infusion, we are able to achieve our target blood pressure of 140/90. So that is how a infusion should be started and how the dosage can be given. Next slide. Now, when you are giving, the infusion, you need to take the blood pressure also at the time of starting the injection, and every 10 minutes for 2 hours, and later on every half an hourly you need to take the blood pressure, heart rate, and the SpO2 of these patients, and keep on recording the blood pressure and heart rate up to 24 hours. So it's very important to monitor these patients, hourly, initially every 10 minutes, and after that every half hourly and hourly for up to 24 hours when a labetalol injection is started. Next slide. So again, training your staff is very, very important. So this is again for the labetalol infusion, how we should monitor. We must remember that the blood pressure, the pulse, the heart rate, and SpO2, these are the 4 very, very important parameters which need to be monitored for our patients who are on labetalol. Next slide. There are certain side effects. So why we are monitoring? Because if there is some side effect like a hypotension, we should be able to pick up. And sometimes because of this, fall in blood pressure, the patient may complain of headache or dryness of mouth. She may have some fluid retention. So, we need to monitor and then we can pick up. So these are not very common, but some patient may say a severe headache, and we should be able to pick it up. We should be able to find out if the blood pressure is falling too low and adjust our dosage. However, for fetus, no teratogenic effects have been found, even if higher doses have been given. Sometimes the patient may have neonatal hypoglycemia, and that's why we need to monitor the baby's blood sugar as well. Labetalol is secreted in breast milk and can cause decrease in the heart rate and blood pressure of the neonate. So you should be informing your neonatologist that IV infusion was given to the mother, and the baby should be looked after accordingly. Next slide. So now, what about non-severe hypertension? This was about hypertensive crisis, how you should give labetalol. In case where the blood pressure is not that high and you're having a non-severe hypertension wherein the diastolic blood pressure is below 110, then you can start the oral labetalol to this patient. So you may need to admit this patient initially for the workup and plan of management, and afterwards you can start the oral labetalol very comfortably. Initially, we start 10 milligram twice a daily, and we monitor the pressure. If the pressure doesn't get controlled, we increase it up to 200 milligram, and usually with a dose of 400, the blood pressure is controlled. Sometimes if higher doses are required, then we may even give it a TDS dose. Let us remember that the maximum dose is 2400. We should not go beyond that. In fact, even if we are having, in 200 milligram TDS, that is a 600 to 800 milligram dose, the blood pressure is not controlled, then we add a second drug. Instead of, increasing the doses, we actually add a second drug. Next slide. What are the contraindications to labetalol? Asthma, then chronic obstructive bronchopneumonia, hypotension, severe hypotension, bradycardia, AV block, a heart failure, Raynaud's phenomena. If there is a hepatic impairment, we should not be given labetalol. So these are very important to remember. And also certain antacids like aluminum or magnesium hydroxide, we should not administer labetalol simultaneously. We should be administering them 2 hours apart. Next slide, please. Now, these patients, how do we monitor them? Those who are on labetalol, oral labetalol at home. We should be teaching them to record their blood pressure at home, and they should be trained to report the blood pressure back to us if it is high. And based on the individual needs of the woman, we should be scheduling the appointment. So weekly appointment if hypertension is poorly controlled, appointments every 2 to 4 weeks if it is well controlled. When should we time the birth? Around 37 completed weeks of pregnancy, if there is a chronic hypertension and well-controlled blood pressure. And if the blood pressure is not well controlled, you are planning early birth, then of course you need to give the antenatal corticosteroids and magnesium sulfate. So if the planning birth is planned early, then of course magnesium sulfate comes to its role comes to play. Next slide, please. So let us talk about magnesium sulfate for neuroprotection in preterm delivery. Next slide. So we do know that in preterm births, there is a possibility of neurological impairments, including cerebral palsy, cognitive dysfunction, educational difficulties, and psychiatric disorders in adulthood. So for all this, it is recommended that antenatal magnesium sulfate should be given for neuroprotection of the fetus in women who are at high risk of very preterm birth. Next slide. So these are the recommendations from FIGO. Next slide. So click again. Yeah, just keep on clicking. So what FIGO, no, previous. So what FIGO is suggesting that if there is a woman is at risk of preterm birth prior to 32 weeks of gestation, then magnesium sulfate is recommended for neuroprotection of fetus. Between 32 to 34 weeks, neuroprotection magnesium sulfate should be considered, and regardless of the cause of the preterm birth or number of babies, we should be administering the magnesium sulfate. So when should we give magnesium sulfate? As close as possible to 4 hours of birth. So suppose the delivery is imminent after 4 hours, then within that time frame, we should be administering the magnesium sulfate. That gives us optimal neuroprotection. And what is the dose? Intravenous loading dose of 4 gram, administered slowly over 20 to 30 minutes, followed by 1 gram per hour as a maintenance dose. And this regimen should continue until birth, but should be stopped after 24 hours if undelivered. So if that baby is not getting delivered, if the preterm labor has set in but not progressed, you need to discontinue the magnesium sulfate drip. Otherwise you continue up to the birth of the baby. That is for neuroprotection. Next slide. So these are the recommendations from these organizations, including WHO, FIGO. So they are all recommending magnesium sulfate. A few, next slide. So these are, again, I'll just follow up. Next slide. So quickly, I'll tell you that there are a lot of trials, like the Pre-Mag trial is there, where 573 women were in the intervention group and the control group, and they all came to that there was a decrease in all the primary endpoints like total mortality, white matter injury, and combined outcomes all were faring better in the magnesium sulfate group. So further slides are again on the Pre-Mag trial itself, and they are talking of the gross motor dysfunction, cerebral palsy, which is all these are very low when the magnesium sulfate is given to the mother where there is a risk of preterm birth. Next slide. Yes, these are another meta-analysis of 5 RCTs where 5,235 fetuses, infants were, in the study group. And yes, post-fetal exposure to magnesium sulfate in women at high risk for preterm delivery significantly reduced the risk of cerebral palsy without increasing the risk of neonatal death. So that's very important that we should know that various studies are supporting the use of magnesium sulfate, and most of us are now using them also as neuroprotection. Next slide. So internationally, these are the brands which are making the ready-to-use magnesium sulfate, and it is very, very comfortable if we have these ready-to-use, bags available. Next slide. In India, we are having this IV Mag. I must say that it is very comfortable when we have this already prepared, IV Mag, which is a magnesium sulfate, which is already prepared as a 4 gram in 100 ml sterile water. So this comes ready to use, and for a private practitioner who is a single person leading the team, then it's very, very comfortable if we have these kind of things available to us. Next slide, please. How to administer? Of course, when we are administrating in a infusion routine, that is our macro infusion set, then it is 8 drops per minute. Whereas if you have a micro infusion set or a blood transfusion set, so it's a micro drip, which we call, then that should be 25 drops per minute. Next slide. So that is how we, very easily we can give magnesium sulfate for neuroprotection. We must know that it may get transferred in the breast milk, and thus infant also has to be monitored with blood pressure, as I have previously said. And of course, we should teach our women that they should monitor their babies for drowsiness, lethargy, pallor, cold peripheries, or poor feeding, and report back. So if the magnesium sulfate has been given, then this has to be the monitoring. In the postnatal period also, some women may require antihypertensives. Quite a few women require antihypertensives, and we can give either labetalol, and I prefer amlodipine instead of enalapril or nifedipine. So labetalol is preferred and amlodipine is preferred. Next slide. What about superimposed preeclampsia? Prevalence in chronic hypertensive women is 25% of women may have superimposed preeclampsia with a new onset proteinuria. So blood pressure rises there and a new onset proteinuria is there. Sometimes there may be fetal growth restriction, but that is not a diagnostic criteria. Next slide. Eclampsia is a severe progression. We already know that when there are convulsions, we call it eclampsia. Next slide. So, so we all know that these are the further criteria apart from the blood pressure rise and protein in the urine. If there is a creatinine rise, hematological complications like HELLP syndrome, neurological complications like eclampsia, altered mental status, liver involvement with an elevated transaminases, uteroplacental dysfunction, all these come under preeclampsia. Next slide. I may not have it. Many a times you may find a swelling on the feet, severe headache, problems with the vision, which you call blurring or flashing, severe pain in the epigastric region, vomiting. These are all sort of premonitory signs. Premonitory signs means this is a woman who is having preeclampsia and she may land in eclampsia. So these are certain symptoms we should be alert about. Next slide. So these are the lab investigations which are advised to predict whether the woman is going to go into later develop a preeclampsia. And one of the very important non-invasive method is the uterine artery Dopplers. Other lab investigations are also available, as you can see, but not many are using it. Very important to note the uterine artery Doppler studies, and that can tell us if a woman can go in preeclampsia. Next slide. For proteinuria, you may use a dipstick screening. You can, once you find that the dipstick is positive, then you should be doing an albumin creatinine or a protein creatinine ratio. You should avoid doing this on a morning first void urine. In fact, a 24-hour urine is more advisable. Next slide. How to manage these women who are having preeclampsia or severe preeclampsia so that they should not convulse. That's very important to know whether we can use some anticonvulsants in these women before they convulse. Next slide. So that is what is, severe preeclampsia management is about. So you have to give an antihypertensive and you have to give an anticonvulsant. Just click on so that we know that what we should be given. So antihypertensive, anticonvulsant is our magnesium sulfate, and of course corticosteroids to develop the lung maturity. So we all know that magnesium sulfate is now the anticonvulsant of choice for our patients with severe preeclampsia. Next slide. There are various trials, next slides, which have already, established the fact that magnesium sulfate should be given in women with severe preeclampsia. Which two regimes are there? One is the Zuspans regime, which is the IV regime, and another is the Pritchard's regime. In the Zoospan's regime, we are having 4 gram of IV loading dose followed by a continuous infusion of 1 gram per hour. So that is a totally IV regime, which is, considered better or the pre-chart regime. Everybody of us have, been taught the pre-chart regime from our residency days. But of course, Zoospan is considered because, the concentration of magnesium is regular. There is no fluctuation. But of course, even Prichtas regime can be given with a loading dose of 4 gram IV, 20%, and 5 gram IM in each buttock. So at 0 hour, you are giving 14 gram, followed by a maintenance dose of 5 gram IM every 4 hourly till 24 hours after birth or after convulsion, whichever is later. Next slide. Hope I'm not going too fast. The Magpie trial, I'm not going to just talk about the whole thing, but yes, it has been proven emphatically that magnesium sulfate prevents seizures, prevents complications. So next slide, please. So more than 10,000 women have been included in this Magpie trial. And as you can see, that is quite a reduction in the risk of eclampsia, as well as the mortality was also lower in women receiving magnesium sulfate as compared to the placebo. Next slide. So this is for women who had pre-eclampsia, not actual eclampsia, but women having pre-eclampsia. So it halves the risk of eclampsia and reduces the risk of maternal death. Next slide. So very important to note that we should be trained, to give the magnesium sulfate in women who are, having severe pre-eclampsia. Next slide, please. So in magnesium sulfate in management of women with severe preeclampsia significantly reduces the development of eclampsia, significantly reduces the maternal mortality as well. Next slide. So these are all, the trial, the Magpie trial itself, which is being shown. And here there is a comparison with other drugs. So in the Magpie trial, we had magnesium sulfate with placebo, and here magnesium sulfate with other drugs. So other drugs also, like hydralazine or methidopa or nimodipine, or the combination, you find that magnesium sulfate is far superior in reducing the incidence of seizures. Next slide. Next slide. Okay, next slide. Recurrent seizures also, even we used to give a resident, but nowadays nobody gives Lytic cocktail regime. We all give the magnesium sulfate regime. Next slide. Yes, this all I have talked about, reduces the risk of eclampsia, and these are the 2 brands available. Next slide. Next slide. So these are the 2 brands internationally available, and in India we have the IV Mag, which is a ready-made bag, which is already available to us for use. Next slide. Now remember that these women of severe preeclampsia, we should be limiting the maintenance fluid to less than 80 ml per hour, unless there is some loss going on, like a hemorrhage. So volume expansion is not required in severe preeclampsia cases unless you are giving hydralazine. And you need to monitor the blood pressure hourly in women with hypertension. In fact, for magnesium sulfate, we have a monitoring regime where we monitor the blood pressure, the pulse, and even the reflexes, the knee reflexes, and the urine output. So urine output is very important. Every hourly, the patient should be having 30 ml of urine. So monitoring that urine output is also very important when the patient is on magnesium sulfate. Next slide. How to deliver, when to deliver. Now, if your patient is having severe preeclampsia, then once she reaches the 34 weeks, so 34 weeks is considered as a cutoff. Your aim is to stabilize the mother and deliver. If possible, you allow, up to 34 weeks, you allow for fetal lung maturity. And if you are planning an early birth, then of course, antenatal corticosteroids and magnesium sulfate, as I have already said, for neuroprotection has to be given. Next slide. Postpartum management, of course, again, once these patients, sometimes you take the patient for cesarean section, you see a very high rise, and you say, okay, now the termination has to be there. You do not give your magnesium sulfate to these women, but these women are at risk of having eclampsia in the postpartum period. So within the first 48 hours is a high risk period. So you need to continue your magnesium sulfate up to 24 hours postpartum to prevent seizures, because that is the high risk period. And often, the placenta, after the placenta is delivered, there is rapid improvement in the condition. There is fluid shift in the postpartum period. So once you see that diuresis is occurring in this patient, you can see that resolution of preeclampsia is occurring, and you rest assured when the a lot of diuresis is there. Potential complications, of course, severe hypertension and hemorrhage, if it's occurring in these patients, then there may be more lasting morbidity in this patient. Next slide. Of course, in the postpartum period, you need to check the blood pressure. You need to, monitor the neurological status of the patient, and also the lab tests like the platelet count, the hemoglobin, the renal function, and the liver function has to be tested every alternate days, every 2 days, till the patient becomes stable. And you may need to start the antihypertensives now in the postpartum period gradually, up to 7 days. We see how she's responding, and over the next 3 to 6 days we can reduce the dosage, and then of course up to 15 days also we monitor, and after that we take a call whether we want to stop this antihypertensive or not. Next slide. So because there is a transfer of antihypertensive to breast milk, especially in preterm babies, we need to train our women, the mothers, to monitor their babies, watch for drowsiness, lethargy, poor feeding, and report back. Medication recommendation, I myself prefer labetalol and amlodipine. I never give enalapril or captopril to my patients, and not even nifedipine. I usually prefer amlodipine in the postpartum period, or labetalol. Both of these are giving good results with minimal side effect. And of course, discharge, we keep in our setum up to 7 days minimal, and after that, with blood pressure monitoring, that patient once is responding well, then we may, of course, the lab parameters have come back to normal, the blood pressure is responding, the mother and baby both are well, then we can consider for discharge and monitoring at home. Next slide. This is how the follow-up should be: weekly follow-up for women, and then 3 months, up to 3 months, blood pressure, urine analysis. And of course, some of these women, because they have gone through a lot, they have stress, post-traumatic stress disorder, and mental health assessment in these women is also, and support is also very, very important. Next slide. Lifelong follow-up, because there is an increased risk of, blood pressure, cardiovascular risk, and thus these women need to be followed up and advise lifestyle modification and maintaining an ideal weight, and later on check for the blood pressure is needed, because sometimes the women may land up with cardiovascular risk. Next slide. So now, this is the last slide, I think, and I want to narrate this case scenario where there's a twin pregnancy conceived after IVF. Initial blood pressure was 150/90. She was admitted at 35 to 36 weeks of gestation for elective C-section. There was no proteinuria. The liver enzymes were slightly high, but everything was okay. The patient was on labetalol 100 milligram for twice a day. She was planned for cesarean section. What happened that her blood pressure rose up to 200/130. Her pulse was 100. And that is when the clinician thought, okay, the blood pressure is rising so much. Let me take her for cesarean section. She asked the anesthetist to report. The anesthetist came. She even asked the anesthetist whether we should be given something to, reduce the blood pressure. And a little bit of response was there. The blood down to 160/90. We know that after giving a regional anesthesia, there is a slight fall in blood pressure. The cesarean section was uneventful, but in the post-operative period, the blood pressure shot up to 180/110. Till 6 hours post-op, the physician started epsilon infusion, but the patient developed convulsions after 6 hours post-op. Now the question is, just a minute, Harshal. So the question here was, the patient has convulsed. So could we have done something to avoid this convulsion? When should the IV magnesium has been used to this for this patient, and could we have given IV labetalol to this patient? I hope that my audience have come to know from the presentation that this is the ideal case which should you have been given, the antihypertensive, the IV labetalol should have been given in the pre-op period only, when the blood pressure has risen to 200/130. Herein, there was a role of even the anticonvulsant, which is your magnesium sulfate. This is the patient who should have been stabilized, and then, because there was no hurry in doing, it was an elective C-section, and hence, if the medications would have been given, probably we would have had a more stable patient with us, and then and even in the post-op period, when the pressure has shot up to 110 diastolic, here was the role of IV labetalol. So I hope all my audience will agree that this patient should have received the magnesium sulfate and the convulsions would have been avoided. So next slide. With that, I think we can open up for discussion. Of course, we know that prophylactic aspirin, antihypertensives, magnesium sulfate, all these are very, very important in the management of pre-eclampsia, eclampsia, and nutritional supplements, lifestyle modification, proper antenatal visits and monitoring. These are all part of the management. But of course, the role of magnesium sulfate is very, very much there, and you have to train yourself and the staff for giving the magnesium sulfate in the cases of severe preeclampsia. Eclampsia, we all know, but your severe preeclampsia, you should be giving magnesium sulfate. So thank you very much. That is all from my side, and now we are open for your discussion. Of course, IV Mag is the ready-made available for us, which we can easily use with comfort. Thank you so much.
Thank you so much, Surekha ma'am. That was an eye-opener. That was a revision of all the things we already know, plus the new things like IV Mag. I was really impressed with this little smart bottle, which can really be a boon to small nursing homes where sometimes we are left with, a very little team to combat eclampsia and any eventual, calamity in the labor room outside. Along with that, you have taken us through all the trials, which have made us aware of which drugs failed us actually, and which drugs stood us in good stead. Neuroprotection is something which is very, very important, because eventually the parent of today is looking for a healthy baby, a baby who is mentally and physically perfect. So thank you so much, ma'am. I think now the lecture is open to comments of the rest of the esteemed guests.
I should say that it is an excellent presentation, and it met with all the minute details. If a PG has missed it, because I had specifically told all the PGs to attend it, and if they have missed it, it is their loss. I should say nothing can be better than this presentation. It was very wonderful presentation. Very nice, Surekha.
I think, Surekha, you really did what I wanted to be conveyed. So very well explained, and I liked your case scenario. And the way you have explained, as Dr. Sumitra has said, that I think it's a loss for those who did not attend it, especially the PG students. The only question rather I had was that with the case presentation that you have shared, so as you correctly said, this case should have been stabilized with 100 ml of the magnesium sulfate solution that you have said. But do you think in this case, post-op also, we had to maintain it with 1 gram per hour?
Yes. So when we start the IV MAG, what we do is we give the 4-gram dose and 1 gram per hour till 24 hours after delivery. Or if the patient has convulsed, then 24 hours after the convulsions. So if sometimes what happens, the delivery has occurred, patient convulses in the postpartum period. So in that case, 24 hours post-convulsion. In case the patient has convulsed in the antepartum period, then 24 hours after delivery. So that is the maintenance dose which is required, 1 gram per hour.
Thank you.
That's
So
standard responsibility.
That's right. So you shown very beautifully the macro set and the micro set. So in a nursing home where only one obstetrician is working and we don't have the infusion pump, do you think with the micro set also we can go with monitoring it 1 gram per hour?
Sure. We can go in. So a macro set is available with us. So I have already mentioned that 8 drops per minute will suffice. If it is a micro drip set, then we can give 25 drops per minute. So that is how you train yourself how to start the drip and what infusion you should be giving. So I think we can be very, very comfortable when we give magnesium sulfate. Only remember that if it's IV MAG, it is already coming in 100 ml, and we are giving it over 20 to 20 minutes of time. 30 minutes is recommended. So, there is no rush. You are giving it quite very, very slowly. In the Preterm regime, we were trained to give a IV bolus, but we used to be taught that you just sit on a stool by the side of the patient, take your own time, watch. 15 minutes is a long, long time. It's a long time. And you have to look at the properly at the watch and give it over that time. In IV MAG, what happens that it's quite diluted, so no need to worry.
Perfect. So I've used this, 100 ml magnesium sulfate, and very closely my staff were watching it. The only thing the patient felt, which I want to share, maybe that could be practical point of view, was a little hot flushes, a little warmth. The patient was feeling. She was saying, I'm feeling very hot suddenly in my head. So maybe that could be because of the effect of magnesium. I mean, I just wanted to share this.
Yes.
Sometimes
garam lagta hai, that's what patient says, but yes, but that's not a thing to worry. You have to watch for her breathing. There should not be a sudden respiratory depression. So that's why you need to put your hand on the pulse. You should train yourself and the staff to watch the breathing. So if there is a respiratory depression or respiratory arrest, that is a problem. That's why all the nursing homes should be having the crash trolley ready. On the crash trolley, you're going to have the calcium gluconate, 10 ml. Okay, and you should be also having the all the tools for intubating the patient. So usually with your 100 ml of diluted magnesium sulfate, you will not have any such catastrophe because you're giving it very, very slowly. But sometimes if the bolus is given very fast, then there is a possibility of respiratory depression, and that is when you will need the calcium gluconate. So you should have calcium gluconate handy on the trolley. That's recommended.
So happy you mentioned about that. So if you recall, it's 10% of 10 ml or 1 gram calcium gluconate. Because sometimes in the market, especially in Gwalior, I'm getting 10 ml of 500 milligram, 10%. We are not getting the 1 gram one. So we have to be a little careful about using it. So these are little tips that I think we should keep in mind.
And we should always check our trolley, what is the expiry date of our drugs, because these are drugs are not needed very regularly. Once in a while you will need calcium gluconate. So what is the expiry date? You should train your staff to every day come and check what is on the crash trolley. Is it available or not? What is the expiry date? And sometimes what happens, the intubation set is there, the laryngoscope is there, but the battery is not
Battery
working.
is not-
So all these things we need to be checking and training ourselves and our staff, to supervising whether the crash trolley is perfectly, in shape.
Very true.
I think,
Madam,
ma'am, the need of
there are a
checking
couple of
patellar
questions in the
reflex.
chat box. There are a couple of questions in the chat box, Rosa ma'am. If
Yeah, please, Monica,
if,
go ahead. Manira, you wanted to say something?
Yeah, ma'am. When we talk about magnesium sulfate toxicity, the first thing we need to check is the patellar reflex. I think that's where we need to check. We are sure that the serum level is between 4 to 7 milliequivalent per liter. So I think our staff and ourselves should be very much versed about checking this patellar or knee jerk. So that's I wanted to
That
add.
is the first to go in case of magnesium toxicity. The first to go is the patellar reflex. So if the patellar reflex is gone, then we should be alert. And even if the urine output is reduced, that accumulates the magnesium in the body. And that is where you have to be alert yourself. That if the urine output is not in the previous hour is not 30 ml, you need not give the next dose of magnesium. Or if it's an infusion, you stop the infusion. That is what is advisable, because
true.
otherwise the toxicity will rise.
That's right.
True, ma'am.
Thank you. There are some questions, Monica. Can you go ahead with the questions?
So there's a question, Surekha ma'am. Somebody is asking from the audience, white coat hypertension to be treated or not? And
What we
similarly, she is also
Yeah.
asking how to diagnose and treat masked hypertension.
So see, white coat hypertension means patient is all right at home, but as soon as she comes to the hospital, there is a rise in blood pressure. But you need not be too complacent, because the rise in blood pressure is there. So you wait, you allow the patient to relax, and you should be taking the blood pressure in the next half hour. After she relaxes, she sleeps on the left lateral position, she relaxes, and then you take the blood pressure. And in fact, you can measure the blood pressure after 4 hours also. So after 4 to 6 hours, if the blood pressure is still rising, then that needs to be treated. So keep the patient under supervision, and if there is a rise in blood pressure, you better investigate, do the workup, and better treat the patient. So it is not like कि अभी blood pressure बढ़ गया और बाद में एकदम normal है. Somewhere there is that tendency. You have to pick up if the patient is having a rise in blood pressure, and if you find that there is a rise, you better treat that patient. And about masked hypertension, nowadays those digital blood pressure instruments are all available for everybody to use. You can train your woman to take the blood pressure at home, and you can identify at home domiciliary blood pressure monitored hypertension, and they may need the preventive measures, and if there is a rise, of course the management is needed.
Thank you, ma'am.
Two questions. Yeah, Monica, any more questions?
Ma'am, I had put the link of the webinar in all over the social media in the morning. So we have amongst our audience a very renowned guest, Dr. Vidyadhar Ranade, consultant gynecologist at Health Advice Call Center, Government of Maharashtra and the NHM Pune. So he has congratulated the speaker and the organizers, and he has given advice to link to a toll-free number of 104 for all patients for hypertension or pregnancy. So this is a toll-free number, probably 104, wherein you can access this number and probably save a woman.
Thank you. Thank you.
Yeah.
That's good. Lovely. So we have a good number of audience. I think we've crossed 105 at this time of the evening. I think a very important discussion. Any other question, if anybody has?
So Surekha ma'am, I just wanted to ask, I know it's a very, very basic question. Does it matter taking a digital reading of blood pressure and the proper mercury sphygmomanometer? Is the
That's a
reading
very,
different?
very good question, Monica. Very, very good question. Because sometimes our digital, blood pressure instruments are not calibrated well.
Yeah.
That may not give us the correct. So, of course, your manometer, mercury manometer, is the standard. we should, but there also, when you are measuring the blood pressure, you should see whether the level has actually come to 0 and then you are measuring. So you need to be very careful, and your digital instruments have to be well calibrated. Sometimes they give you very false readings. So good calibration of instrument is very important. Otherwise, many a times when I am not, sure whether my digital blood pressure equipment is showing the right blood pressure, I go and do it by the, your mercury manometer. That is the standard of this. But when we are talking of, our staff nurses taking the blood pressure, a digital instrument is really handy, but see to it that it is well calibrated.
Yeah. Thank you, ma'am. Thank you
Ma'am,
so much.
can I add something here?
Yeah, please go ahead, Manila. Please go
Yeah,
ahead.
ma'am. As per the current times, as what I have read, I may be wrong, but it is a liquid crystal sphygmomanometer, which is supposed to be used these days over mercury one. And this aneroid devices which we are using for now, they are obsolete, and the automated, as ma'am already said, has to be calibrated to what standard BP instrument we are using in our clinic. So that is what was my knowledge on it. And you can add.
But definitely, as I've said, calibration is very important. So if it is well calibrated, you have checked, your instrument is well calibrated, then you can use. But of course, your sphygmomanometers is the standard.
Yeah, ma'am. That liquid crystal sphygmomanometer, that what they say should be used these days.
So is it available, Dr.
Yeah, it
Manila?
is available.
I don't know if it's available. It is available, but we are still using the mercury.
The mercury.
So, ma'am, we have around 160 doctors attending as of now. And Dr. Hema Trivedi has asked another question. Many times IV labetalol does not control BP in postpartum period, especially in women having, you said labetalol is contraindicated in pregnant women having asthma. Then she said, can you use nifedipine? Is it safe enough?
You can use nifedipine, you can use amlodipine. In the postpartum period, there are a number of options.
Yeah.
So sometimes if the blood pressure is not coming down, your anesthetist may use a nitroglycerin drip as well. So, but if oral nifedipine is good enough.
Yeah.
And what is the dose of nifedipine? So what are the dose that you would recommend?
2 milligram, we should not be giving the sublingual one. 10 milligram orally, 10 milligram, it's 4 to 6 hours is the half-life. So you have to repeat it every 4 to 6 hours.
That's right.
Yeah.
Thank you so much. Thank you so much, Surekha, ma'am.
So Rekha, just a question for most of the interiors, doctors working in the interiors. Suppose the blood pressure is, for example, 160 by 100, and it's not coming down. So the doctor doesn't want to deliver this patient in an interior nursing home, a small place. What could she or he do? Should she give the magnesium sulfate 100 ml and then transfer the patient immediately to a bigger center? What is your take on that? How do we manage in smaller centers?
Magnesium sulfate is recommended when the blood pressure diastolic goes above 110. Okay, that is the recommendation. If the blood pressure is above 110, then give the first dose, your IV dose of 4 gram, and transfer the patient. That is fair enough. So if it is diastolic 100, then you give your oral drugs, you can give nifedipine, and you can transfer the patient. But if it is going above 110, safely you can give the IV magnesium, your initial loading dose, and transfer the patient.
Does the blood pressure come down after giving magnesium sulfate?
Yes, magnesium sulfate, once you give magnesium sulfate, the blood pressure does come down. That's why it is recommended that you should not be given your IV magnesium sulfate and nifedipine together, because both are working as a calcium channel blocker. So you should not be giving together. You should be having at least 2 hours of duration between a magnesium sulfate and a nifedipine, because magnesium sulfate will also lower the blood pressure. Nifedipine will also lower the blood pressure. So we should not combine these 2 drugs.
That's right. And what about labetalol along with magnesium sulfate?
Usually, these, because the mechanism of action is different, but still, what is recommended that when you are giving one drug, you should not combine immediately another drug. because magnesium sulfate itself will lower the blood pressure. So watch for the blood pressure. In the next half hour, if you find, so there is an hypertensive crisis still exists, then you should be giving the IV labetalol as well.
Perfect.
Both
Perfect.
should be given together.
That's right. Lovely. And the heart rate should be always high, more than 100 by giving labetalol, because it decreases the heart rate. So in bradycardia, we don't give labetalol.
So you should not be having severe bradycardia. That is the only thing of concern. So
Okay.
because it reduces the heart rate. So even a 90, 80 heart rate is fine, but not below 60.
Below 60. Perfect. Perfect.
Yeah.
So these are some important points that, one has to consider while using, especially when you're into interiors or you're alone, you don't have a physician and you have to manage things on your own. So are there any other questions, or we can wind up and finish?
It is very safe. Only thing we have to be careful of is not give it very quickly. That you have to be. So with an IV mag available in 100 ml, it's very safe because you are recommending to give it over 30 minutes. So that's why it is safe. Nobody should be afraid of giving IV magnesium sulfate if proper recommendations are followed.
Perfect. This is a very good take-home message that we all start using 100 ml magnesium sulfate. So thank you so much. I think this is time for me to say the vote of thanks to my dear speaker today, Professor Surekha Teyade, all the way from Maharashtra, which really, I must say, to the point, it was something that everybody absorbed, because the questions speak in itself how much the audience are listening to you. So thank you so much with your case presentation, with your clarity. And I think the final count of doctors is 165. The message has come. So lovely to have you and I hope to have you in person in Gwalior next time that we can make a CME in person.
Tomorrow I'm coming to Raipur. I was supposed to be there in Gwalior today, but
I
had promised the annual chapter of Chhattisgarh also, the state annual conference. So I thought I cannot go to places.
No, I'm sure you did a good job anyways here, but I hope we can have you again in person. More about updates. So thank you so much, Surekha, for being with us, taking out your time. I would also like to thank my chairpersons who are with me at this moment, all of you. I think Dr. Sumitra Yadav, Monica, and my dear Manila. Thank you for coordinating it so well, Manila, from the beginning, and Monica, as always, putting good questions up front and making it more interesting. And I would also like to thank all the delegates who are present here with the questions that you've put forward is well appreciated. Right across India, we're having so many societies joined together. My last but not the least is Blyson, which is Blisson. I have to pronounce it. Mr. Naveen, Mr. Parag, and the whole team,
so
which is, been really actually looking after the whole event so beautifully. And I didn't have any trouble making things, organized, because it was so perfect in doing it. So all of you, thank you so much for your patient hearing, and I look forward to see you all soon in person again.
Thank you, Dr. Rosa, and thank you all my chairpersons, Manila.
Thank you, ma'am. Thank you. It was a pleasure listening to you, ma'am. Thank you, Rosa, ma'am, for giving me this opportunity. Thank you, Sumitra, ma'am, Monica, ma'am, and the Blisson team. Thanks a lot.
Thanks for the opportunity, Rosa, ma'am.
Thank you, everybody. Bye.
Bye-bye. Good evening.
Thank you, ma'am. Thank you so much, everybody.
Thank you.